All right. Let's go ahead and call this meeting to order. Good afternoon, everyone. Welcome to the meeting of the SURG Prevention Subcommittee, June 20th, 2023. I really appreciate everyone logging on. With that, we'll go ahead and do the roll call to establish quorum. Ms. Rodriguez, can I turn this over to you for the roll call?
All right, Chair Johnson.
Present.
Debbie Nadler.
Present.
Angela Nichols.
Present.
Eric Schoen.
I am here.
Madam Chair, we have a quorum.
Wonderful. Thank you all for joining and 100% attendance. Nice work. We'll move to item number 2, which is public comment. So this public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. It will be limited to 3 minutes per person. And no action may be taken upon a matter raised during a period devoted to public comment by the general public until it's presented on the agenda. Ms. Rodriguez, can we open public comment, or is there anyone for public comment?
Yes, I just admitted somebody on the phone. It looks like they were able to join. I don't see any hands raised. I'll give it one more moment. All right, I'm not seeing anybody indicating they would like to provide public comment at this time.
Wonderful. Do I need to pause for a moment for the person on the phone for public comment?
I'm not seeing it. It looks like they joined, and I'm not seeing any indication that they wish to come off mute.
Terrific. All right. With that, the first period of public comment is closed. We'll move to agenda item number 3. We will review and approve the minutes from the May 15th Prevention Subcommittee meeting. I'll pause for a moment if my fellow committee members needed a chance to review the minutes. And once you do, I'd entertain a motion for approval.
So moved. For the record, Eric Schoen.
Wonderful. I have a motion on the floor from Eric. Do I have a second?
I'll second that. Debbie Nadler.
Wonderful. And a second from Ms. Nadler. All in favor, say aye.
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 Any opposed? Any abstentions? All right, minutes have been approved from the May 15th subcommittee. Thank you, everyone. With that, let's move to agenda item number 4, our prevention subcommittee recommendations for review and discussion. This is for a possible action today, and a big thank you to Emma and Margaret from SEI who put together the recommendations that have been submitted thus far today. Ms. Rodriguez, can I turn it over to you to walk folks through how you've organized this, if that's all right?
Sure. Emma Rodriguez for the record. So we, as you all know, had set up that Survey Monkey so that subcommittee members could submit recommendations. And so far we have received 6 prevention subcommittee recommendations in 2023. On the following slides, they'll be summarized. And they're also, every single entry is in a PDF document that you might want to download from the SURG website. It might make that easier to follow along. So the next slide right here, this just has a summary of kind of the main topics for the 6 recommendations, and then the slides after that just go one by one. So Chair, I'm not sure how you want to go through them, so I'll turn it back to you and I can help wherever is good.
Terrific. Thank you so much. I'll give folks sort of one moment to download that information. My recommendation is that We go through these, I know you have them laid out on each individual slide, and the opportunity from this group to share if there are additional clarification or areas that we'd like to clarify the recommendations at this time. The goal will be to get them in a place where we can present at the July full SURG committee meeting of sort of where we're at thus far. So I would vote to go through slide by slide unless my colleagues have any additional recommendations.
Chair, this is Eric. I think that's a great idea. I would support that.
Terrific. Thank you, Eric. Appreciate that. All right, so we can go ahead. So the first recommendation that we had was around the DEA Operation Engage. We received a presentation from Ruth Morales, the community outreach specialist from the DEA, to our subcommittee regarding the programs and services offered broadly by the DEA. I wanted to just make a quick reference to a communication that was shared with us last August of 2022 as we think through some of these specific program recommendations. To refresh the memory of this committee, we received a communication from Dr. Kearns on behalf of the AG's office with the SURG around the clarification of our roles as SURG members. So I'm just going to read sort of what I have on my end, because this is how I was thinking through some of the guidance from today. So the SURG does not make direct grants to any program, but rather makes recommendations to DHHS on the use of funding to address the impact of opioid misuse or other substance use disorders. So when discussing programs or organizations with which a SURG committee member is affiliated, the member should make that disclosure or state their intention to abstain from any specific motions or casting a vote prior to any discussion. And then if we're unsure, to paraphrase, if we're unsure if we have a conflict, seek guidance from the Attorney General's office. So I also think that in the interest of this committee, looking through many different types of programs to address prevention, there's an opportunity to think about how we might generalize this work statewide. I know there are a couple of recommendations for specific program names. My discussion or suggestion to workshop this recommendation today is to look at something that is more broad, that says increasing awareness and support of prevention programs. And that might be a recommendation that could apply to a few of the specific program names that have come in. So I'd love to hear from the other committee members who are on today about a broader recommendation out of this committee around increasing an awareness of support of prevention programs. What are your thoughts?
Can I say something? I'm sorry, my hand raised thing doesn't work. This is Debbie Nadler for the record.
Go ahead, Debbie.
Thank you. So you're talking about everything or just this one particular thing? You're talking about a broader approach to all the recommendations, correct?
Yeah, so thank
Okay.
you for the opportunity to clarify. Jessica Johnson for the record. So I'm looking at, I think there are a couple on here. So this recommendation number 1 is kind of a specific program. And then recommendation number 4 is also sort of a specific program. And given the diversity of the communities across the state and the need to address prevention as it's sort of relevant to the local data and conditions, using evidence, of course, my recommendation would be to combine these two under an increasing awareness and support of prevention programs or evidence-based prevention programs. So that we can have something that applies to more locations and work.
Okay, can I just make one comment? Sorry about this, but the DARE program right now, I don't know if anybody's familiar with it, but I talked to the man in charge, and it's going in Washoe. I never can say that county, Washoe County right now. And the cost, I mean, I know we don't deal with cost. I know we do recommendations, but it's a relatively low cost. They just have to train. I've got everybody's numbers. I've sent them in. They have made the DARE program so intense now. It's middle school, it's elementary school, it's high school. And I'm just making a recommendation that everybody look it up, what they're doing, because they're doing it up north. And I'm not sure why they're doing it in one part of the state and not the other. It's kind of, I would like to be consistent, like what they do up north, we should do down south. We know addiction doesn't discriminate, or the desire to use a substance doesn't discriminate. So it would be for everybody in all schools. That's my thought. Sorry.
No, thank you, Debbie. I really appreciate this opportunity for discussion. Maybe I can clarify a little bit, and I know we'll get to recommendation number 4. I'm not trying to jump ahead. I think I'm recommending that rather than have like the DARE program or the Operation Engage, which are specific programs that communities could select if they identify the needs for their particular communities. It sounds like maybe some folks in Washoe County specifically identified the needs or outcomes of the DARE program, but to lean into the presentations we had in May from some of the statewide prevention experts around evidence-based prevention programming, and looking at making maybe a broader recommendation about increasing awareness and support of evidence-based prevention programs, or some other broader recommendation for then communities to dive deeper into looking at the evidence.
So, Chair?
If I could just, oh, I'm sorry. Go ahead, Eric.
Oh, okay. No, I was just going to say, so just, I like where you're going with this. I mean, I think our job is to elevate sort of the main points, right? In terms of suggesting where we should be focusing our energies and our attention. So my only concern about the language you're recommending, and I'm trying to come up with my own sort of in between, is it's so broad. I mean, generally, I think there's maybe acknowledgement, but it sounds kind of like what I've heard the last 30, 40 years. We need to increase investment in prevention. I don't know if that's enough heft or substance to really be actionable enough. So I'm trying to find a middle of the road where it's not too specific, but also not so broad that people go, oh, yeah, we should be investing more in prevention and all those things. We know that. Thank you for the recommendation. Does that make sense?
Definitely. I really appreciate that suggestion.
Well, I'm trying to come up with a solution myself of what the middle language might be, and I do not have anything. So I don't think I've given you anything yet, except yeah, if anybody else has ideas for what that might look like.
Are you talking about like dividing up the prevention, like primary, secondary, tertiary? Like as far as, here's my thought, and I'm sorry, and I don't mean to be wordy on this, but we have to think outside the box. Obviously, what these evidence-based programs, whatever they may look like, whatever they may be, are not working. We are losing kids 12 years of age and up. It doesn't, I feel like we don't have to necessarily focus on an evidence complete based program. I think maybe a combination of certain things, and just like you were saying, Jessica, putting some things together. And Eric, yes, I agree with you. It's very broad. It's not defining. We're losing too many kids, and it's got to stop. And the only way to stop it is to prevent it. And how does that look?
Well, so what about something like this that might, so for the record, Eric's shown something that might be a little compelling. double the amount of investment in prevention programming year over year for the next 5 years? I mean,
Yeah.
that's a reach, but it would be something measurable. It'd be something tangible. It's basically making the point that we need to, if we want to get in front of it, what Debbie said, and Jessica, what you've said, if we want to get in front of this, we really have to increase significantly our commitment and level of investment in prevention.
Yeah, Jessica Johnson for the record. Emma, I think we want to hop back to the recommendation number 1. Thank you for taking notes on this slide so we can visualize.
Sorry,
No worries.
struggling over here. Thank you.
No, I appreciate your flexibility here. And I'm really grateful for this discussion. So I like the idea to either to suggest something more actionable, so double the investment. I also was thinking about to somewhat of Debbie's point around reach. So I don't know that we know the saturation level of the prevention programs. What I learned from the presentation last week was that funding is a major barrier to that. So I'm wondering if something to the effect of double the amount of investment in, we could say, primary prevention programming. We could maybe put some age specifics around that from 0 to 24 or whatever the recommendation is age-wise, to, I don't know, to reach some sort of a threshold or a saturation. What are your thoughts from the group on that type of a recommendation?
Well, so to Debbie's point, and I think we have historically underinvested in so much infrastructure. It's like, where do you start? I mean, I'm thinking of a car with all 4 tires that are flat. Which of the tires do you start with? It doesn't really matter as long as we start getting one of the tires ready. So if we want to focus on primary prevention, we want to focus on the whatever age group, wherever we start is a good start.
I agree. Yeah, I agree. And didn't we just win 2 more lawsuits or 3 more? Don't we have $800 million? I know it's coming to us in increments, but we have more money now. Sorry, I'm just bringing that up.
So it may be helpful to work from a baseline. So knowing what we mean when we say double. And I don't know if off the top of my head, if Ms. Ross and if Jamie and Hannah presented on that the last month or not, but perhaps we could reach out to them to get an estimate, or maybe to someone at this state committee who could help us get an estimate of what this is looking like at the moment. So I wanted to ask, sorry, go ahead.
So I have a clarifying question, because you state, which I appreciated you doing at the beginning, we can't make funding recommendations. And I know this is stated as a funding recommendation by doubling the amount of investment. I don't mean it so, when I use those words, I wasn't so much meaning to make a funding recommendation is to make a point, like we would double the level of energy, we would double, right, resources devoted.
This is Jessica Johnson for the record. So to clarify, it says the SURG does not make any grants to programs, but makes recommendations to DHHS on the use of funds to address the impact of opioid misuse. So we could make a recommendation to DHHS to double the amount of investment in primary prevention programming, or some other entity, whoever oversees those dollars.
I like that.
And then for the record, Eric Schoenigan, I actually think this is too low of a, we're going to double the amount, maybe. So I initially had said year over year. So every year we would double, but I don't know that they have that kind of discretionary ability. So maybe every 2 years they would double to be in line with how often the legislature meets and approves their budgets. The department heads do as well. So maybe double the amount of investment in primary prevention every 2. Yep, there you go. You got it.
And Emma Rodriguez, for the record, if I may, it was 0 to 24, the age group. I wasn't sure if there is primary prevention for like an infant.
There is. I don't,
Okay.
I mean, there's health promotion programming, to my knowledge, this Jessica Johnson for the record, all the way down to preschool. So, and primary prevention programming in some instances can look like evidence-based adequate childcare is been demonstrated over time to help improve outcomes and for families and for children. So we may need to be a little bit more specific if there's different types of programming that the committee is looking for. But in general, this feels much more actionable than where we started. Thank you for the opportunity to workshop this together.
Can I
thoughts?
make a comment? Yeah, I'm sorry.
Yes.
This is Debbie Nadler for the record again. Emma, to answer your question, actually, just like Jessica was saying, it does start, it's like big change starts small. So what they're doing in the UK, for example, is, and you can look this up online too, Kate Middleton started it with the kids. It's more of a social and emotional mental health, feel good, do good type of thing in preschool. And then as they progress into elementary school, more levels get added to it. But the infrastructure does start when they're very, very young, because as we all know, there's some sort of mental trauma that exists for most, I'm not saying all, but for most people who pick up a substance, they're picking it up for a reason, to feel good. So we have to divert that, like pick up a puzzle instead of a drug, just something like that. I'm sorry, this is my big thing. Sorry.
No, thank you, Debbie. This is Jessica Johnson for the record. I really appreciate you chiming in, and thank you for the fantastic question. So go ahead.
Sorry, Emma Rodriguez for the record. Thank you both. I just wanted to note that we'll want additional justification, kind of explaining both what Chair Johnson and Ms. Nadler said, so that when a legislator or whoever is reviewing this report will have all of that background information who wasn't part of these meetings. So I think as we go through this, if subcommittee members are able to make notes for, supporting information that they would want to go along with these recommendations in the final report, that would be helpful. And then I did have a question for Rosalie. Should we be taking votes on all of these at the end, or what's your recommendation? These are just preliminary recommendations at this point.
Rosalie Bordelove for the record. It really depends whether you are wanting to kind of be able to eliminate things or just creating this as a working document. I don't think you really need an action until you're making something that is being sent on behalf of the committee and and the subcommittee, a statement. So if this is really just kind of where your working document is, and you're going to bring this back up in the form it is at a later meeting as you move forward, I don't think you need to. Any final recommendations or direction to staff to compile something or forward something on your behalf would need a vote.
And then Chair Johnson, for the record, Eric Schoen, I would say not only would it be good to Emma's advice to make sure we're describing the the younger age for what primary prevention would look like, but also the older ages as well. I think most folks, and I may be wrong, but most folks, when they think of prevention, they think of it occurring within
what time is it out again?
the K through 12 school system. And so if we could provide justification for both sides of that, for expanding that age range.
Jessica Johnson for the record. I think that's a great piece. And so as we come up with these additional drafts, we can send them back out, hopefully on SurveyMonkey, to add in the additional supporting areas so that it's a very robust recommendation with lots of resources included for anyone who may want to implement this recommendation as we go forward. So specifically on the data for age ranges, I think will be helpful, and on the recommendation itself and around primary prevention programming. And within that, we can link to specific examples, or I know was shared with the group resources for people to look at what the prevention programming can look like.
Can I just add one more thing? I'm sorry, this is
Please
Debbie
do.
Nadler for the record. And I look at this as prevention. And I don't know where this would fit in, but I've called Nevada State Board, I've called everybody. They do it in Washoe County. The kids in middle school and high school, on the back of their cards is a helpline. You can either scan it. I'm not sure if they have the scanner on there, but it's got the mental health line, drug use, suicide hotline. And I've called the school board here in Clark County, and it's not being done. And I think that's a prevention, or I don't know what that falls under, but I think it would be something that would be a fast, doable thing for our state, you know, to give the kids some resources.
Thanks for your question, Debbie. Jessica Johnson for the record. So I believe we discussed this question at our May 15th meeting, and Ms. Ross, if to my recollection, replied that I think Safe Voice is included, at least currently, on middle school cards at CCSD that she has seen. And so I think that maybe answers part of your question. And then to answer the other part, I would really invite this as to be put in as a recommendation for this subcommittee for consideration. Today, I know we really want to focus on sort of what we've received thus far, so we can share progress at the July meeting. But I would invite you to add that in as a recommendation for us to discuss as part of this group.
Okay, thank you.
Forward.
Thank you.
Yeah.
But by the way, middle school kids that I know at the schools around here, they don't have it on the back of their cards. I'm just saying for the record, they do not. Okay, sorry.
Thanks. Any other discussion on this recommendation workshop before we move to the second one? All right. Ms. Rodriguez, I think we can move to the next one. So this is Jessica Johnson for the record. There's a prevention subcommittee recommendation number 2 is around increasing support for youth vaping prevention. I am going to recommend that the committee pause on this until we have a presentation scheduled at our July 17th prevention subcommittee meeting from Malcolm Allo from the Southern Nevada Health District to talk a little bit more about the youth vaping programs throughout the state and in Southern Nevada, some of their outcomes, and provide some recommendations. So if the committee is in support, I'd like to move on to see if there are other recommendations we can spend time workshopping on today, so we can wait to hear from Mr. Allo.
I agree, Debbie Nadler for the record.
Thanks. And I'm seeing Mr. Schoen shake his head on camera too, so we can go ahead and move on to recommendation 3. Great. So prevention subcommittee recommendation number 3 is around accurate drug testing resources into communities. And we had a presentation from Dr. Tracy Green at our last committee meeting in May. And would love to hear the workshopping from this committee. I also just wanted to note before I open it up for discussion, I think there is a similar recommendation in the harm reduction recommendations, which we're going to talk about next in this group. So if the committee is open to it, I'd love to maybe hold on this one and see how it might be the same or different from the harm reduction recommendations. Thoughts from committee
agree.
members on that approach?
I agree, Debbie Nadler. Thank you.
And I heard Mr. Schoen say that works. Okay. We'll fly through these, Emma. Hopefully that'll keep us on track.
For the record, Eric Schoen, that works.
Great, thank you. All right, recommendation number 4. So this one is regarding the DARE program. As recommendation number 4, I would move to integrate this and any future ones that are about specific programs into the workshop recommendation that we created for number 1, as a way to perhaps strengthen the recommendation information we discussed for number 1. What are the thoughts from the committee on that approach?
Yeah,
Debbie Nadler, for the record, I say yes. Eric, did you?
Yeah, I thought we had covered in our workshopping of number 1, basically number 4 at the same time.
Terrific.
Yeah.
All right, Chair Johnson, for the record, we're moving on to number 5. All right, this one, recommendation number 5 is around alcohol outlet density. We received a presentation on this from Jamie Ross and Ann Elizabeth during our May 15th prevention subcommittee meeting. In putting together this recommendation, I had taken some notes on what Ms. Ross verbally sort of recommended in terms of alcohol outlet density regulations. There's a lot packed into here. One opportunity or point for discussion might be to integrate these into a singular broad recommendation around taking action or a BDR request, I think, is one of the options we have for this around alcohol outlet density, but open for discussion from the committee on how to workshop this. Thanks.
Boy, this is a tough one. Sorry, Debbie Nadler, for the record. I mean, it's one and the same, alcohol, drugs, but I know we have such an increase in alcohol, and I'm kind of at a loss for words on this one. I'm sorry.
Thank you, Debbie. So, this is Jessica Johnson for the record. Eric, you are the wordsmith on this committee, so I'm happy to. We could.
Well, so I don't know if I have an all-encompassing poetic phrase to capture it all. For the record, Eric Schoen with Eric Schoen. So I think we almost have to sort of. There's a number of directions being pointed to by Jamie in this, Ms. Ross in these recommendations. So if we don't yet have a statewide report on alcohol outlet density and associated outcomes, that seems like a really good place to start. Like, could we, if there's nothing, because I'm not sure, what was compelling for me, and I'm sure for some of you, was how that alcohol density information could then be utilized. But I'm not sure we even have a standard or a comprehensive approach for capturing that information. So maybe one of the recommendations could be codifying or institutionalizing an annual report, or however often it can be updated, so that policymakers and those of us who do this work would have it to reference to make reference to.
Jessica Johnson, for the record, thanks, Eric. I think that is a great first step. I would include in that perhaps some evidence-based recommendations or action items from the report, inclusive of the data.
Well, so then I imagine, so maybe there are other places that already use alcohol density information. And maybe at certain alcohol densities, certain actions are activated. And so maybe in certain areas that have a high alcohol density over a 5 or a 10 or whatever number that would be, then some of these restrictions might kick in. A board looking at this might say, hey, you know what? We already have super high alcohol density. There's no reason we need to have these kinds of promotions. So once you get to 10 or more, then you're shut off from this kind of advertising or something else. But it would be another tool by which we might be able to better target our interventions for what we're trying to do, what we're trying to accomplish.
Jessica Johnson, for the record. I think this is a really good place to start, and all of the information in here, perhaps having at least a solid understanding of the statewide data for this work would be an important component.
Well, and for example, I heard shown for the record, I see it here, regulating new alcohol outlets near areas of recreation for children. Maybe it just becomes part of state law that if you have alcohol density over some preset number, there just won't be any further approved alcohol establishments. Or maybe that has to be adopted into county code. I don't know where that is in the law, but we would have a tool to point to. And if we could find evidence-based ways that this has been used successfully elsewhere, and it may be really, I think I could see this being a really potent tool.
This is Jessica Johnson, for the record. I'm in favor of sort of the modifications to this recommendation at this point around this statewide report for reference. I think that of all of the items in here, it kind of gives a level setting place to start. So thank you for that, Eric.
Sure.
Other discussion from the committee members on this recommendation?
But so for the record, Eric shown, my only in looking at the verbiage that's been written here, I don't want it to be a one-off statewide report. So I don't know how to put it into words, but a living, breathing document that would be updated regularly. And I don't know what a reasonable expectation is. If it's something that could be pulled monthly, great. I don't know what that looks like yet.
This is Jessica Johnson, for the record. Are you perhaps instead thinking about some type of a dashboard or a data point
Right.
that could
Yeah.
have
Mhm.
some more regular
Absolutely.
data input?
Yeah.
And is there, this is Jessica Johnson, for the record, is there a specific entity to which making this recommendation would be helpful? Is this a DHHS recommendation, or
Isn't there an office of sorry, for the record, Eric shown, isn't there an office of analytics within the state?
yeah.
I don't know if this would be appropriate for them or not. But their dashboards are pretty sophisticated and pretty good. I can imagine this being something that could fit right in there.
Jessica Johnson, for the record. Thanks, Eric. So make a recommendation to, we could say DHHS parentheses Office of Analytics, or the appropriate location to create a data dashboard or other type of report. Keep it open on alcohol outlet density for policymakers. Other type of, sorry, I want to back up, or other type of report, like a regularly updated report, to your earlier point, Eric, for policymakers to reference. And I guess if it's a dashboard, we wouldn't have evidence-based recommendations for interventions. So just trying to workshop here.
Yeah, no, I think it's almost two recommendations. One is you have this regular report, but then it's going to be a learning curve for how we can best utilize that information. is to start maybe making a significant difference with that. So I'm not, because it's a new tool and I'm not familiar with how we can use alcohol density, I can imagine what it looks like. I think we will have to really do a deep dive into how we could use alcohol density information or how it's being used elsewhere throughout the country or the world effectively and maybe not so effectively.
Wonderful. This is Jessica Johnson for the record. So then would you recommend, based on the text that's in blue on the screen, to omit starting at for policymakers?
I think so. Yeah. I think the first thing is let's just get a regular dashboard up that has the information. And then the second step is let's figure out how to use it. I mean, to really simplify it, right? Let's make the report and then let's figure out how to use it.
Great. Any other input from the other subcommittee members? This is Jessica for the record. Sorry. All right. Hearing none, I feel like this is appropriately workshopped. So thank you for the insight. And I know this was an area with a lot of passion at our last prevention subcommittee meeting. So I really appreciate it. And thank you again to Ms. Rodriguez for taking notes and helping keep us on track.
Yeah.
All right, let's move to recommendation number 5, number 6, apologies. So this one again is a recommendation for a specific program. I'd move that perhaps this could be included with our funding recommendation that we included in recommendation number 1, but open to committee input or opportunities for discussion.
For the record, Eric Schoen, I agree with you.
Debbie Nadler for the record. It is, are we going to have Amanda Wilson speaking about the program so everybody knows what it's about as well?
Jessica Johnson for the record. Debbie, we could do that at a future meeting. I'm curious, based on our earlier discussion about having kind of broader statewide recommendations, is that something that we'd still like to move forward with?
Yeah, my only thought, this also ties in with harm reduction. So it's a dual. It's not prevent. This is more harm reduction. Well, I guess that's what we're talking about. But yeah, I say we move it to the future. I mean, I say we have her speak to us and hear what she has to say and what it's about before I guess we can make any recommendations or.
Okay, so perhaps recommendation number 6, we're going to review the harm reduction recommendations next. As we were the committee tasked with that duty as well. Could we be open to maybe looking at those and seeing if this approach or recommendation fits within one of the recommendations for harm reduction that's already been suggested?
I think that sounds good.
Okay.
Debbie Nadler for the record.
Thank you. Just Chair Johnson here. For the record, Ms. Rodriguez, I'd like to hang on to this one for a moment as we look through the harm reduction ones with recommendation 6 and recommendation, I think, number 3 around the drug checking in mind. All right. Any other discussion from the prevention recommendation item before we move on to agenda item number 5? All right, hearing and seeing none, we can move to agenda item number 5, which is reviewing the harm reduction recommendations for review and discussion. So as I just briefly mentioned, our subcommittee is tasked with reviewing the harm reduction recommendations out of the larger general SURG meeting that happened in April. So there were 9 responses collected. So this is our opportunity to do some additional refining, and reporting out of suggested revisions will happen at the July 12th SURG meeting. So there is helpfully, again, an additional PDF with this information on the full survey responses if there are any additional details that are needed. Ms. Rodriguez, is there anything else you want to add before we look through these?
I'll just note, Emma Rodriguez, for the record, that so just to refresh everybody's memory, we had that meeting with the full surge in April, where we had all the presenters present on their harm reduction recommendations as suggested by the all of the surge members. Following that meeting, we distributed a survey to all of the surge subcommittee members, just with their feedback, because there were multiple recommendations within each category, to try to get a sense of if there was a consensus on whether, you know, people really liked a certain recommendation or if they really didn't want one to be considered. And this is just information for the prevention subcommittee to take into account. So on the following slides, I'll just go to the first one. You'll see these answer choices. So these were all of the recommendations that were discussed in that April meeting related to the Bad Batch app. Of the 9 surge members who responded to that survey, 6 were in agreement with the recommendation to support for expansion of services across Nevada's 5 behavioral health regions. 1 person said they don't want any of these recommendations to move forward. And then Margaret and I added, if there was any additional commentary, that's below. And so this is just for the prevention subcommittee to take into account. I think the idea, and Chair Johnson can explain this better than I can, would just be to kind of for this subcommittee to decide which of these recommendations they want to take and kind of form it into one recommendation. This will then be presented at the July surge meeting. So rather than having all of the surge do what we're doing, it just kind of makes it a little bit more nimble. And hopefully we can take it, you know, the ideas that the other surge members had.
Thank you, Ms. Rodriguez. If the opportunity for us to workshop here is in this version of screen sharing mode. So I also know the PowerPoint is available on the website too, if you're in need of a little bit bigger font, totally appropriate. Thank you and zoom in. Emma knows everything. I love this. Thank you, Ms. Rodriguez. So the goal here would be to, we can review the answer choices around what was presented at the meeting, and then the comments on the bottom are for additional consideration as we're developing the committee recommendations, and then we'll type on the right hand side. So we'll give our best go at the Bad Batch app recommendation. Any opportunity for clarifying questions before we get started?
So for the record, Chair Eric Schoen, so we only get 1 recommendation per slide. Is that what I heard Mr. Rodriguez say?
Not necessarily. This
No.
Jessica Johnson for the record. Not necessarily. I think our goal is to, based on what is on, and I think this one may be the longest one that we're starting with, based on what is on the left, if we want to combine any of them, reconfigure them, add them together, break them apart, that from this we would come up with like a workshop of the recommendations. Sort of what we've been doing, if that helps clarify.
Debbie Nadler, for the record, can we combine 1 and 2? Can those be combined somehow? I mean,
Jessica Johnson, for the record, the short answer is yes. We can combine the answer choices. To clarify the number of responses, just sort of were in the order of where when people voted on the survey, sort of
right,
what they selected. was a priority for them. So first on the table is to integrate answer choices 1 and 2, perhaps support expansion of services across Nevada. Sorry, go ahead, Mr. Schoen.
Oh, no, I'm sorry. I mean, so in looking at, so if we, the top 4 seem to work really well nested together, right? Like if we had an app that was used statewide that could be integrated with drug checking services to give alert users of potentially lethal batches, it was maintained on a regular basis, and then we could deploy public health and harm reduction resource. I mean, that's all of kind of the holy grail of what you're hoping to do with bad batch apps, right? So if we could capture all those top 4, man, that's like a golden goose recommendation.
Sounds good to me. Debbie Nether for the record. I'm not a wordsmith, you are, Eric.
Well, but it's pretty convoluted. I get that. I mean, it's like 4 discrete, like kind of bite-sized steps, but it really does seem like those Russian nesting dolls, they nest really well with each other. So if you had an app that was used and then was maintained and was integrated and then supported with additional service, wow, that would be an awesome outcome.
Jessica Johnson for the record. I agree, Debbie. I'm not a wordsmith either. Grateful always for Eric adding in his thoughts. I had a couple of ideas for consideration as we think through this. To the point of one of the comments, I don't know if the term, we could use bad batch app in quotations. Perhaps there's another type of name that would be more appropriate for community members or folks who might utilize it, that would help them gravitate more towards the usage. And then so open to discussion on that. My second point is that as part of our work on the joint task force, I was actually tasked with bad batch app presentation. So stay tuned for those of you tuning in next week to the joint task force, where I'll be talking about bad batch app myself. One of the things that I learned in looking at that is that there hasn't been an evaluation done on the impact of bad batch apps. So if this recommendation moves forward, I would include the opportunity to rigorously evaluate the impact and the use or the reach, I guess, of the app.
And Chair, for the record, Eric Schoen, I also had those same questions. I was the one who wrote, I have no preference regarding bad batch apps because I don't know enough about the research supporting their efficacy. They may be really efficacious and I just may not know it, but given what you just said, yes, I think it's really important that we evaluate this if there is not any data that currently supports that. Because the history of drug and alcohol prevention is littered with good intentions that didn't have a desired outcome. So don't want that to happen here, obviously, as well.
Jessica Johnson for the record. Given that comment, and I appreciate that, perhaps we unnest this nesting doll and perhaps the first recommendation is to like pilot and evaluate the use of bad batch app type services across Nevada or in a particular behavioral health region. And based on sort of the results of that evaluation, consider expansion.
I like that.
And support. I don't know. Yeah, sorry, Jessica Johnson for the record. The other consideration too is that each county has an outbreak, a spike response plan. So in that evaluation, I think it would be important to determine if this could be data that could be in consideration for how this would impact the spike response and what that might look like as a data point for public health and harm reduction services.
Good point.
So the implementation pieces of that, to my very baseline knowledge, are at least detailed out for multiple counties. So I don't know if this is two separate recommendations as Emma has it here, sort of nested within one another, or what the group's thoughts are on this approach.
So I appreciate your, sorry for the record, Eric, Mr. Chair. I appreciate your the last thrust of your comments there. I'm not sure that the Russian nested doll recommendations, I don't know that those should go forward at all. I think we need to be careful, and I like your idea of doing a pilot project, and then based on those results, perhaps it could be expanded. But all of the nested doll recommendations are sort of predicated on this being an effective approach that would be worthwhile to pursue. And at this point, we simply don't know that yet.
Jessica Johnson, for the record. So what I'm hearing you say is that pilot and evaluate the use of bad batch app services. Perhaps my recommendation is personal that I cannot pronounce this. And in one behavioral health region, like, period.
Yeah.
Sorry to make you type all of that, Emma. And then can we add the component about rigorously evaluate the impact and reach of the app to determine, and then perhaps add something to the effect of to determine expansion or next steps.
Well, yeah, effectiveness, and then
Effectiveness.
yeah. I mean, yeah, how do you define effectiveness? Is it working well with the other indicators, like you talked about, the opioid spike rates? Because it's interesting to think about the interplay between what that data is capturing, what this would capture. Depends how nuanced the information that we're getting on these bad batches can be, and if that's corresponding with an increase in the opioid spike reports or a decrease. Are we seeing fewer spikes, right, as we use a bad batch app in that area? I could see this really having a number of ramifications.
Jessica Johnson, for the record, thank you for that. So then I would move to, we could eliminate the other well discussed text.
Emma Rodriguez, for the record, if I may ask a question.
Go ahead.
During the meeting in July, do you want to have the discussion about the bad batch aim and potentially see if other SURG members have an idea for what to call that? Or do you want to just keep that in the report as bad batch in quotes?
Jessica Johnson, for the record, I am fine with keeping it in quotes. I just think perhaps it would be important to know who the intended target audience is, if this is if the name is Bad Batch app, or if there's a better way to describe or how folks might be gravitating towards it. That's a little bit more, I don't know, attractive or of community in a way that could be more effective. So to make a long-winded comment longer, I think I'm okay with leaving it for now.
Mm-hmm.
Thank you for asking. Other thoughts on this recommendation? All right. So wonderful. So we'll move to the next recommendation on the quantitative drug checking. This is the one that also relates to one of the prevention subcommittee suggestions from Dr. Green. So I'll pause for a moment so folks can read through some of the answer choices. Thoughts from this group on how to translate this into a recommendation?
Yeah, Ms. Chair, for the record, Eric Schoen, this feels almost like it's going to be a repeat of our last conversation. Some of these strategies are, I think, relatively new. I could be easily corrected to be wrong, but I'm not super familiar with the level of drug checking that we're recommending, where it would almost be down to the molecule of what substances are in these batches and whether or not that information would be helpful for people to make good health choices. It seems intuitively on this side of it, somebody who's never had an addiction, it seems intuitively, but has worked in addictions, it seems intuitively that it would follow, but I don't know that to be true. So I also don't know if this would be the most helpful things for people who are actively in addiction. They might say, hey, well-intentioned, appreciate it, but really, honestly, and it might also depend too on the level, how easy it is to do the testing. If they have to go to a police department or someplace like that, I can imagine that would really be dissuasive. Like, I don't really want to go there. I don't feel welcome there. I go there, I'm going to be arrested. Whereas if it could be more ubiquitous, like fentanyl test strips, and we have safe places for people, quote, safe places for people to go, it might dramatically change the perception of the utility of that kind of service.
Thanks, Mr. Schoen. Debbie, were you going to add something?
How'd you know that? Okay, so Debbie Nadler for the record. When I think of quantitative drug checking, it leads me back to what the legislator just voted on. When I think of it as you have 4 pounds of 4 grams of heroin, and I'm sorry, okay, heroin or cocaine, whatever. They and a trace amount of fentanyl, but they don't know the actual quantity of fentanyl. I think this more is important when it comes to young kids buying pills, because if they buy 10 pills and let's say 9/10 of the substance is cocaine or whatever else, they're going to go to jail because of the new, and I don't even know if that law passed, and I should have followed it, but I think it has to do more with jail time, the quantitative drug checking, because if there's 4 grams of fentanyl, then a 12-year-old's going to go to jail, at least from the proposition that was gonna put through, and I don't think it passed. I know in California, because my son passed away there, they do both qualitative and quantitative drug checking specifically for deaths, so for prosecution. So when I think of that, that's what I think of. It has more to do with imprisonment. And if people are using recreationally, I don't know, I've got thoughts all over the place, but we can't imprison our way out of this epidemic. And I think, if I'm not wrong, quantitative drug checking has to do with this, and I could be wrong.
Thank you for your comments, Debbie. Jessica Johnson, for the record. I just wanted to add, so from the full disclosure, the health district is doing qualitative drug checking as part of our ODTA funded grant from CDC. So I can speak a little bit in that capacity. So I believe Marco Mendez from SNHD presented on this during the harm reduction presentation. So how that works is in collaboration with the local syringe services program. So closer to answer choice number 4, they collect refuse, so discarded paraphernalia that's available at the SSP. They swab that to put through a machine specifically that they use to analyze for drug checking that has some hoops to jump through, like a bachelor's degree in chemistry, for example, to read the output. But then they also swab the residue and send it to a lab that analyzes for qualitative. So that's essentially a list of the active and inactive substances that come back. I don't know that all of these submit to the quantitative drug checking, which be submitting to a lab that could then say, this percentage of the sample that you sent me was xylazine, this percentage was fentanyl, etc. I'm wondering if, based on Dr. Green's presentation, which is taking in additional data that wasn't necessarily received by the whole committee, my understanding of the process in Rhode Island is that through syringe services programs and outreach programs, they work to do the in the field swabbing for qualitative drug checking and then send the sample off for kind of confirmatory quantitative drug checking that's more used for surveillance than it is for informing folks sort of on the street. So I don't know if that's helpful or more convoluted to this discussion, but I wanted to just add it for consideration.
And for the record, Chair, I am inclined to support that because that's a path that's already been established. I liked when I heard that presentation, I liked how once I was able to wrap my brain around it, how that additional information from a surveillance perspective would be really helpful for those of us on the public health side trying to allocate resources and make sure we've got our services lined up. We also heard, I think, either that in the same day that the technology, like honestly, until we can test it with our cell phones really easily, I'm not sure testing will be widely embraced. It might be. Again, I don't know. This is just me making my own suppositions based on what I understand from human nature of my 54 years around the planet. But I think we're a little ways off from having easily accessible technology that makes testing super easy and not an inconvenience. And until we can get to that point, I'm not sure we're ready for a formal bad batch testing program beyond what you just recommended, following Rhode Island's example.
And Ms. Jessica Johnson, for the record, Ms. Rodriguez, with the opportunity to pull in what Dr. Green's recommendations were to our committee. Thank you, Ms. Rodriguez. So I'll give folks a moment to read through these as well, because perhaps our recommendation back to the full SURG is to consider something that has a little bit more of a system to it, or an opportunity to work with either Dr. Green or an affiliate from that project to help provide some consultation to scaling up a statewide approach.
For the record, I like it. It's similar to the recommendation we made just a minute ago to have a pilot. And this is a nice way to start and see what kind of traction this might have and see who the natural partners are.
Jessica Johnson, for the record. So this would allow us to, I think, prior to creating a pilot program, perhaps establish a statewide initiative for drug checking that incorporates qualitative and quantitative drug checking. From my remedial understanding, both of those have merit and are scalable in different ways for different communities based on need. And then to implement, establish a state, sorry, now I'm reading what you wrote, Emma, thank you. Establish a statewide initiative for drug checking that incorporates qualitative and quantitative drug checking and includes the following parameters, perhaps. And then we have some of these bullet points, such as work with harm reduction community to identify partners. Start all sites with mail-based testing, while identifying the early adopters. Standardize the data collection, and then plans and principles. Are there any items from the additional answer choices that we'd want to include? I know this is a little bit wordy.
Can Debbie Nadler, for the record, would this have to do with mandatory drug testing in the hospitals, which they're not doing? Tyler's Law, which was passed in California.
Jessica Johnson, for the record, no. So this is community drug checking. That is a fantastic, but perhaps separate recommendation around hospital checking. But good example and idea. Hopefully, something we can look at a future prevention subcommittee meeting. That is a helpful clarification, though. Emma, could we say establish a statewide initiative for community drug checking? I think to clarify, per Debbie's point. I'm just reviewing what we had in the answer choices to ensure to identify. So I would add to the work with harm reduction community to identify partners and location and perhaps provide guidance and training. Might be too many ands in that sentence, but that incorporates some of the recommendations from the first one. I know we're running a little low on time. Additional thoughts on this one before we move to some of the other recommendations? I think this is wildly improved. Okay, hearing none. Let's move to the shipping program efforts. Expansion of harm reduction services in every county. Go ahead, Debbie.
Is this another thing we can combine them all? I mean, yeah, I mean, I think they're all, especially the top 1, 2, 3, 4, for sure.
Yeah, Debbie, this is Eric. You're not wrong. These all, I mean, they all work well together.
Jessica Johnson, for the record. So I am aware that folks can access the shipping program through Next Distro. I think my understanding and recollection is one of the barriers is specifically around like addresses in some of the rural and frontier areas, and the barriers with actually getting like harm reduction supplies to people through shipping specifically. So I'm wondering if, I think in order to expand to some of the rural and frontier areas, I imagine the components around travel costs and perhaps some advertising would be the most, like the highest priority for implementation. Because as it stands now, supply shipping is sort of happening like through Next Distro via Track B exchange, but there are some barriers to both ongoing funding and the delivery of the supplies to rural and frontier areas.
So that makes sense. Debbie Nadler, for the record, Jessica, are we still I heard, and again, I remember I asked this last time, are we short on our supply of Narcan? Are people having trouble getting it? I'm seeing it across the country. I don't know what's happening in our state.
Jessica Johnson, for the record, thanks for your question, Debbie. I don't know that I can answer that at this time, but I'd be happy to chat with folks here and get back to you offline.
Thank you.
Emma, what's your recommendation on next steps? Do you have any thoughts?
Well, I was trying to follow along, Emma Rodriguez, for the record. So were you suggesting, Chair, to focus the recommendation on the travel costs one and leave the rest of these off, or did you want to incorporate some of these into this recommendation?
Jessica Johnson, for the record, I think my move to this group is to think about the associated travel costs and barriers regarding addresses or locations for delivery of the supplies, in addition to the advertisement components, and that the rest of these, I think we can are important, but as related to the shipping efforts, I think secondary.
And Chair, would you like me to remove the sentence about the two cities? Okay. How does that?
Can I I'd recommend perhaps adding one sentence that says like establish alternative strategy if if people can't receive delivery of mail or of delivery of the supplies. Hopefully we have a chance to wordsmith that more at the larger SURG committee. All right. This is around post-overdose outreach. I know that this is a co-recommendation, I believe, with the joint task force as well. So this, Chair Johnson, for the record, so this to me is analogous with some of what we discussed earlier around kind of a recommendation for a specific program and wanting to kind of broaden those efforts. So one thought here is to have a broader suggestion that is increased support for harm reduction based post-overdose outreach with law enforcement or with public safety.
Well, there's actually, Debbie,
broad.
I'm so sorry, Jessica, Debbie Nadler, for the record, really there's two different outcomes. There's death and then there's survival. So as far as the post-overdose outreach, there is a sentence in here and it's pretty important. I thought I saw it in here. It had to do with funeral expenses. Other services would be funeral related, housing need. There's a whole nother side. It's the families, the counseling, the services. As of now, there is nothing provided to us. I'm speaking for myself, but I'm really speaking for a lot of the parents here. We're paying for our own counseling. Our kids are suffering. There's really two sides to this overdose, the death and the ones who survive. If there's a way to split that up or put it together, or I'm not sure. Again, I'm not good at words, but I know what I'm thinking.
I appreciate you sharing that, Debbie, and definitely elevating this is continuously important. So thank you for that piece. I I see Emma added here, including perhaps these like really needed services. And these are just some examples of what might be provided. Full disclosure, in the program she's talking about, I'm involved with, so I don't know that I can really be too involved with the specific program side of this. So I think that's where having a broader recommendation around increasing programs like that include harm reduction based support and maybe perhaps wraparound services for families. If it is a fatal overdose that these folks are responding to, may help to not only broaden this particular recommendation, but ensure that the additional supports are there.
That's good. Debbie Nadler, thank you.
Great, thank you. Thank you so much.
Chair Johnson, can I ask a question?
Yes.
Emma Rodriguez, for the record, did you want me to delete this part, and so just leave it at wraparound services for families, or to include that additional detail?
Jessica Johnson, for the record, I'll defer to the committee on this. I could say to include, or for example, or including, such as some type of examples of what we're hoping these like the linkages to services could look like, but open to other committee members' thoughts on this.
I think a couple, for the record, Eric Schoen, for the some keywords that I heard were wraparound services, and then I didn't really hear this word, but it's sort of like post-mortem, right? This is like the difficult work of ameliorating trauma after the worst outcome has happened. So being, rather than sort of giving a family a list of here you go, being proactive and trying to help them actively anticipate and make their way through, and somebody there who can help sort of act as a guide and a support.
Maybe put the word fatal overdose in there. Family, surviving family members. Again, I'm not good with the words, but as far as the wraparound, providing services for family members, something with a fatal overdose, they're surviving family members maybe.
Thank you, Mr. Schoen and Ms. Nadler. So what we have so far is increased support for harm reduction based post-overdose outreach with public safety. Perhaps we should say including wraparound services for surviving family members and or post-mortem services for families. Parentheses, for example, services could be funeral related, housing needs, healthcare, counseling, or a warm handoff to treatment for substance use disorder.
Yes, Debbie Nadler for the record.
Great, thank you. Thanks, Ms. Rodriguez, for keeping us on task here. I know we have about 7 minutes left. The next recommendation we received was on alternative pain treatment. I'm happy to spend some of our 7 minutes here, but one thought I had in reviewing this was to recommend that the Treatment and Recovery Subcommittee take this specific recommendation on to review. This seems a little bit more in line with their purview, but open to the group's thoughts if you'd like to spend time here discussing.
Debbie Nadler for the record, I agree with you, Jessica.
Yeah, and for the record, Eric Schoen, it seems like it's a little bit out of our wheelhouse, honestly.
Great, wonderful. So we'll recommend that that committee review this one. And the next one is on safe smoking. So we had several presentations around safe smoking. Safe smoking supplies or tools for people who use drugs. this is how the committee voted. I'll give a moment for folks to review this. My initial thought in looking at sort of where Nevada's at with safe smoking might be to reframe this recommendation around a BDR, a bill draft request at the legislature to change the language around drug paraphernalia as it relates to smoking supplies. Other states who have looked at that from a public health approach or perspective have then been able to allocate additional resources to these types of projects or programs. I don't know what the committee's thoughts are on that, or if there are additional answer choices that would make a better recommendation.
Debbie Nadler, for the record, I agree with you, Jessica. Good.
And for the record, Eric Schoen, I'm not sure I don't remember this presentation, so I don't feel like I have enough background to be able to make a recommendation. I'm happy to follow what you're recommending.
Terrific. All right. Given that, I think we can move to our last one. Is that correct, Emma? With 4 minutes to spare. So this one is around the community health workers. I know this is an area that we want to continue to track over time as this develops. So the last one is around providing support to the coalitions, funding for community health, or funding for community health workers.
So I think you could easily combine those first two, provide support and prioritize funding for community health workers to provide community-based harm reduction services.
Agreed, Debbie Nadler.
Great, I hope we aren't losing steam. I wanted to just note here, Jessica Johnson, for the record, that SB 117 did pass during the legislative session, which authorized Medicaid coverage for community health workers who provide services under the provision of a physician, physician assistant, or advanced practice registered nurse.
Yay.
All right, I think we got through all of our recommendations. Round of applause for this committee and staying focused with 3 minutes left in our meeting. And a big thank you to Ms. Rodriguez for helping us stay on task.
Absolutely.
Wonderful. We can move on to agenda item number 6. So this will be a brief discussion on the report out for the July SURG meeting. So the plan is to prepare just a brief summary of the progress that we've made on the prevention and harm reduction recommendations. These won't be final drafts, but will reflect the discussion of the meeting today for the larger group. We had also mentioned ensuring that we revisit the recommendations from the 2022 report. So in future meetings, we'll want to ensure that we have the areas integrated across these prevention subcommittee recommendations, particularly if there were ones that needed additional research. And as we finished up the 2022 report, that we're identifying those going forward. Ms. Rodriguez, was there anything else on this discussion item?
No.
Wonderful. With that, I'll close agenda item number 6. And with a few minutes to spare, open for our last agenda item number 7, which is a public comment period. Again, public comment will be received via Zoom by raising your hand or unmuting yourself. Public comment can be limited to, or shall be limited to 3 minutes. And no action may be taken upon a matter raised during public comment. So with that, Ms. Rodriguez, do we have anyone for public comment?
Chair, I do not see any indication at this time that anybody would like to provide public comment.
All right. With that, I'll go ahead and close the public comment period. And we can move on to agenda item number 8, which is adjournment. So thank you to the committee members for your dedicated on-task engagement today. I'm really proud of us for getting through such a robust agenda. And thank you to Ms. Rodriguez and the SEI team for helping us stay organized.
Yep.
Thank you, Jessica. Thank you, Emma. Thank you, everybody. Y'all are awesome. Thank you.
Good to see everybody. Take care.
Take care. See you all in July. Thank you again.